A white bag slides across a pharmacy counter. Inside is a 30-day supply of a drug a physician named last week. The clerk reads a number. You pay $40. The receipt looks complete. It is not. Behind that receipt, a health plan pays a different figure. The pharmacy receives a third. A manufacturer books a list price that matches none of them. Between those numbers sits a firm you did not choose and cannot see on the bag. That firm is a pharmacy benefit manager. Health plans hire pharmacy benefit managers to control prescription costs. The assignment sounds clean. Process claims, assemble pharmacy networks, negotiate with drug makers, keep the plan from being billed into ruin. Then the invoices refuse to line up. The same intermediary paid to restrain spending can earn money when list prices stay high, when a preferred drug wins formulary space, when a pharmacy is reimbursed less than the plan is charged, and when a related mail-order pharmacy fills the script. The cost control agent occupies the payment chain and can profit from the thickness of that chain. This is not a story about one boardroom. It is a story about a market rule. An insurer, a self-funded employer, or a public program hires a specialist to police drug spending. The specialist then sits at every joint in the transaction: manufacturer to plan, plan to pharmacy, pharmacy to patient. Each joint can carry a fee, a rebate, a spread, or a steering incentive. A contradiction opens. If the hire is working, why does one pill generate so many prices? If the hire is failing, why do large plans keep signing? Rebates, formularies, spread pricing, networks, vertical integration. Those tools make the arrangement rational to the people who contract for it and bewildering to the people who swallow the pill. The question is not whether pharmacy benefit managers exist. The question is what they are paid to do and what else the chain lets them do at the same time. In the United States, that chain now runs through a handful of firms most patients cannot name.
Most Americans still picture a prescription as a triangle. A clinician writes, a pharmacist counts, an insurer pays whatever remains. That picture is the historical blind spot. The missing actor arrived as paperwork. In the late 1960s and the 1970s, health plans drowning in paper drug claims began hiring specialists to process those bills. The first pharmacy benefit managers were not household names. They were back offices. They keyed claims, checked eligibility, and mailed reimbursements. The work looked like plumbing, and for a time it was. Then the medicines themselves changed character. Through the 1980s and 1990s, branded therapies multiplied, and managed care organizations tried to police utilization instead of paying every bottle on equal terms. The processor gained a new instrument, the formulary. Preferred products, non-preferred products, prior authorization, step therapy, quantity limits. A plan could no longer treat every prescription as a simple indemnity event. Someone had to rank the bottles. Pharmacy benefit managers moved into that ranking. They also moved into the manufacturer's conference room.
A drug maker that sought its product in the preferred column could offer a concession. The concession often arrived as a rebate, a retrospective payment tied to volume, share, or exclusive placement. The plan sought a lower net cost. The manufacturer sought access to covered lives. The intermediary held the list that both sides needed. This was not a coup, it was a contract. Employers and insurers did not want to staff a national pharmacy desk. They sought one vendor to build a network, adjudicate claims in real time, and return a report that said spending had been managed. Specialization looked like discipline. Public insurance then enlarged the same machinery. When Congress passed the Medicare Prescription Drug Improvement and Modernization Act in 2003 and Part D coverage took effect in 2006, the United States layered a vast new drug benefit onto private administrators. The statute did not invent the pharmacy benefit manager. It multiplied the number of people whose monthly tablets would pass through one. Years later, the Government Accountability Office examined how selected states attempt to regulate the sector.
In that review, auditors documented functions that ordinary conversation skips and contracts cannot. These firms administer prescription benefits. They negotiate rebates. They affect drug pricing. They use pharmacy reimbursement arrangements, including spread pricing, in which the amount billed to a client can differ from the amount paid to a pharmacy.
Those sentences are job descriptions, not accusations. What patients still miss is that a drug price is not a sticker. It is a stack of ledgers, a list price, a negotiated rebate, a plan's payment, a pharmacy's reimbursement, a patient's copay or coinsurance, a dispensing fee, a network clause that can change the reimbursement after the fact. Each layer can move without the others moving in the same direction by the same percentage or on the same Tuesday. That is why a medicine can appear cheaper at a cash counter than through insurance, or more expensive on an explanation of benefits than the number spoken at the register. The figures are not failing to agree. They were never required to be one figure.
Health plans hired this apparatus because prescription spending became large enough to threaten premiums, union negotiations, and public budgets. No single local insurer sought to invent a nationwide claim switch and a rebate office from nothing. Buying the function looked cheaper than becoming it. Buying the function, however, also bought a fog. Once an intermediary owns the formulary logic, the electronic claim, and the pharmacy contract, the plan has outsourced not only labor, but line of sight. Sponsors can still demand pass-through rebates, they can still commission audits, they can still write tighter terms. The daily geometry of the market still runs through a vendor whose own revenue can live inside those same choices. A profession was built to keep prescription costs from running wild. The specialist hired to sit beside the plan learned to sit between the manufacturer, the pharmacy, and the patient. Commerce is full of middlemen. The blind spot is narrower and stranger. This middleman was retained as a cost control function and then permitted to become infrastructure.
The easiest mistake is to hunt for a single mind. There is no single mind. There are 4 ledgers, and each one can win a day that the others lose. Start with the plan sponsor. That person is not paid to understand every rebate clause. That person is paid to keep next year's premium from exploding and to offer a drug benefit that labor will not riot over. The pharmacy benefit manager arrives as relief. One contract, one network, one set of reports. Someone else will fight the drug makers. Someone else will tell the local pharmacy why the reimbursement changed. The sponsor's motive is not cruelty. It is exhaustion, plus fiduciary fear. The sponsor's quieter motive is lock-in. Complexity itself becomes a reason to renew. Once claims, prior authorizations, and specialty pipelines live inside one vendor, ripping the vendor out looks like a year of chaos. Switching costs protect the hire, even when the hire is resented. Now the manufacturer. A brand team lives or dies by access. If the formulary parks a drug in a disadvantaged tier, prescriptions migrate. If the formulary makes the drug preferred, volume follows. A rebate is the toll for that gate.
The manufacturer's motive is not to make list prices pretty. The motive is to buy a position on a list that millions of covered lives will actually use. None of that requires a cartoon of greed. It requires a gate. The independent pharmacist occupies a different clock. Reimbursement files can turn a break-even fill underwater by evening. Network participation is oxygen. Leaving the network means losing customers whose plans will not pay. Staying means accepting terms written far away. The pharmacist's motive is survival of a storefront that still counsels people by name. The decision is whether to accept a contract that may pay less than acquisition cost on enough generics to hollow out the weak. A pharmacy owned inside the same corporate family as the manager lives on another incentive. Mail order and specialty channels can capture the fill that used to walk through a Main Street door. Steering need not look like a threat. It can look like a lower copay, a 90-day supply, a specialty exclusive. The patient experiences convenience. The independent store experiences disappearance. The patient is the character with the least paper. No one asks the patient to initial the rebate exhibit. The patient meets a copay, a denial, a transfer to mail, a preferred brand that is not the brand the specialist preferred. The motive is ordinary and stubborn. Obtain the medicine without a second job in appeals. And the pharmacy benefit manager itself? Its motives are plural, which is the entire problem. It can be paid as a faithful agent. It can also be paid from the same joints it polices. Those streams do not automatically point the same direction. A choice that helps a client may starve a spread.
A choice that fattens a rebate may protect a higher-list brand. A choice that fills at an affiliated pharmacy may be defended as quality and attacked as self-dealing. No faction has to be lying for the system to hurt someone. They only have to optimize the number they are judged on.
A pharmacist in 2024 scans a bottle. The claim leaves the store in a second. It hits a switch. Somewhere, a pharmacy benefit manager's engine reads the member, the drug, the pharmacy, the day's supply. Rules fire, formulary tier, prior authorization flag, copay, reimbursement. The screen lights green or red. The patient is still holding a credit card. That second is the market. Watch the rebate first, because it is the concession everyone cites and almost no patient sees. A manufacturer needs a preferred rank. The manager negotiates a retrospective payment, often calculated on utilization that has already occurred, sometimes improved if rivals are excluded or disadvantaged. Money later flows from the drug maker toward the manager. What happens next depends on the client contract. Some sponsors demand that rebates be passed through. Some share them. Some buy a discount guarantee and let the manager keep whatever it can extract above the promise. The same word, rebate, names several different property rights. A staff-level concern follows from that design, and it must be kept in qualified language.
If a plan is shown savings as a rebate against a list price, a high list paired with a high concession can look like a victory on a spreadsheet, even when the net is not the lowest net available. Patients who pay deductibles or coinsurance tied to undiscounted or list-adjacent figures can meet a harsher number than the plan's net. That is an incentive problem, documented as a concern. It is not a proof that every contract raises every patient's price. The formulary is the lever that makes the rebate real. Prefer a drug and volume moves. Disadvantage it and volume flees. Utilization management, step therapy, prior authorization, quantity limits can be medical stewardship. It can also be bargaining power. The distinction is not written on the rejection slip. The patient sees a delay. The manufacturer sees a threat. The plan sees a tool. The manager sits where those three descriptions overlap. Now, spread pricing, the arrangement auditors have named in state-facing work. The manager bills the client one amount for a fill. It pays the pharmacy a smaller amount. The difference is the spread. In a pass-through model, that difference is supposed to collapse toward a disclosed fee.
In a traditional model, a spread can be a revenue line, sometimes defended as the price of a guaranteed discount to the sponsor. The sponsor may honestly believe it bought predictability. The pharmacy may honestly believe it was paid below the cost of the bottle. Both can produce documents. The documents will not match because they were never the same document. Imagine a generic tablet, not as a real invoice, but as the arithmetic the rule permits. The plan is charged $12. The pharmacy is paid $7. The patient pays a $3 copay that may or may not be netted the same way in both ledgers. $5 has to live somewhere. If the contract assigns that $5 to the manager has earned a return for moving a claim that took a second. If the contract assigns it back to the plan, the manager must live on fees. The economic fight in state houses is often a fight over which of those assignments is legal, disclosable, or banned. Pharmacy networks tighten the same second. A wide network is convenient and expensive to police. A narrow network can be sold as quality or as leverage. Reimbursement terms can be less favorable outside a preferred subset. A fill can be steered toward mail order or specialty by copay design rather than by a prohibition. The patient is not told they are a bargaining chip. They are told their copay will be lower if they use this door. Vertical integration folds the doors into one corporate family. An insurer, a manager, and a pharmacy can share a parent. Then the referee owns a team. Formulary influence, network design, and dispensing margin cease to be three companies' problems and become one enterprise's portfolio. A staff report can describe the structure and the potential effects without proving that every affiliated fill harmed every member. The potential is the point. Incentives inside a family do not police themselves. In July 2024, the Federal Trade Commission released an interim staff report on prescription drug middlemen. The staff analysis documented that the 6 largest United States pharmacy benefit managers handled more than 90% of prescriptions in 2023. It described concentration. It described vertical integration.
It described formulary influence and effects on pharmacies. The language matters. This is staff work. It is interim.
It speaks in the grammar of incentives and potential effects, not in the grammar of a verdict against every contract. Hold that beside the Government Accountability Office's state regulation work without blending them into one chorus. The fact that 6 firms handle more than 90% of fills does not mean that a particular copay in a particular city was inflated. The fact that plans hire managers to restrain spending does not mean concentration is irrelevant. And then the present tense tightens. A legislature writes a license rule, a spread ban, a disclosure mandate. The firms adapt the contract. The claim engine updates. Independent pharmacies testify that reimbursement still arrives below acquisition cost. Plans testify that ripping up national contracts will raise premiums. Manufacturers testify that they must pay for access. Patient groups split between those who seek any leverage against list prices and those who have been denied a specific therapy because a rival paid more for the preferred slot. No scene ends with a gavel that restores a single price. Reports accumulate. Contracts renew. The switch keeps lighting. A small group of intermediaries can influence which medicines millions of Americans receive, which pharmacies fill them, and how costs are distributed among sponsors, pharmacies, manufacturers, and patients. The wound is that the decisive second, green light or red, remains privately coded, commercially confidential, and economically loaded. The wound stays open. The aftertaste is not outrage. Outrage expires. The aftertaste is a quieter recognition about how a modern market keeps itself from drowning. A health plan does not hire a pharmacy benefit manager because it prefers opacity. It hires one because drug spending is a storm of codes, launches, shortages, specialty pipelines, and manufacturers who will not offer the same concession to a lone employer that they will offer to a book of millions. The hire is rational on the sponsor's page. Delegation is how large organizations survive their own benefits. Rational for the signer is not the same as simple for the patient. The patient was never in the room where the net was defined. The patient is the person the net was supposed to protect, and the person most likely to meet a copay that was never the net. Once a society allows an agent to live at every joint of a payment, the joints become valuable. Fees attach, rebates attach, spreads attach, affiliated dispensaries attach. None of that requires a conspiracy meeting. It requires only that the agent be paid, in part, from the friction it was hired to compress. Compress the friction, and one revenue dies. Leave the friction, and the client still has a report that says management occurred. This is the principle sitting in the invoices. An incentive looks insane from the sidewalk and inevitable from the contract. The sidewalk sees one pill and seeks one price. The contract sees a portfolio and seeks a net, a guarantee, a network, and someone else to sue. Between those aims, a profession grew that is neither a charity nor a simple thief. It is a priced pipe. Pipes are not optional after the city is built. That is the aftertaste that lasts. Employers can tighten audits. States can license and ban and disclose. Commissioners can issue interim staff reports. Sponsors can demand pass-through terms. Transparency statutes travel more slowly than claim software. The software does not wait for the hearing. Each of those actions is real. Each still travels through the same claim second. The infrastructure remains the infrastructure. There is a temptation to tidy the story into a single reform sentence. Ban spreads, pass through rebates, break affiliations, build a public administrator. Each proposal moves one ledger and surprises another. A spread ban can push margin into fees or into pharmacy ownership. A rebate pass-through can leave the list price problem untouched for anyone whose cost sharing is not based on net. A breakup can scatter bargaining power just when purchasers say they need more of it. The wound that would not close in the hearing room does not close in a slogan. So the image to leave is not a villain's face. It is a green light on a pharmacy screen and a set of dollars parting around it like water around a piling. Some dollars go to the maker, some to the store, some to the plan, some to the patient. Some remain in the piling. The piling was installed to keep the river from flooding the town.
The piling is still a piece of timber that collects a toll in the current, year after year, whether the town is grateful or tired. If the specialist hired to control prescription costs is also paid by the thickness of the chain, what exactly is the patient supposed to call the price?